Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear friends in my surgery lecture number 46, that is the bust abdomen and the incisional hernia. In this lecture we will cover the bust abdomen, that is the abdominal wound dehiscence, incisional hernia and its types and treatments, divarication of the recti and lumbar hernia. Now start with the bust abdomen. Bust abdomen means the abdominal wound dehiscence. Means the abdominal wound means the wound which is taken for the incision for the any type of operation of the abdomen, and that wound becomes the dehiscence, that is the bust abdomen. The content of the abdomen come through that wound, that incision, that is the bust abdomen. When an abdominal wound gets open or disrupt, the condition is called bust abdomen. The incidence of bust abdomen following abdominal operations is approximately 1 to 2%. This is usually seen between the 6th and 9th day after operation, but disruption of the wound occurs earlier in the deeper layers. So in case of the partial disruption, where only deeper layers gap, the superficial layers remain opposed even after removal of the sutures. There is a possibility of developing incisional hernia. Now the factors which are incriminated to cause bust abdomen are: first is the factor relating to the patient, that is the obesity, advanced age, multiparity, malnutrition, peritoneal dialysis, jaundice, hypoproteinaemia, anemia, malignant disease, all important factors which contribute to the development of the bust abdomen and incisional hernia. Coughing and vomiting. Dear students, here is the image you can see on your screen, that is the dehiscence of the wound. Wound is totally gaped and the internal organs of the abdomen is clearly seen in this image. This is the second image. The dehiscent wound is closed by the deep tension suturing in complete wound dehiscence by the tension sutures. Now the second factor which are incriminated to cause bust abdomen are the choice of incision. Midline vertical incision tend to heal slowly and are liable to disrupt more than transverse incision. Second, the type of operation. Operations on pancreas and peritonitis are liable to cause bust abdomen or develop subsequent incisional hernia while closing the abdominal wound, and through incision tension suture should be applied. Third, faults by the surgeons are method of the closure. Interrupted and through suturing of the abdominal wall has low incidence of bust abdomen than continuous stitching of the layers. Now the fourth, choice of the suture material. Obviously, use of non-absorbable suture material lessens the chance of bust abdomen than that in case of use of absorbable suture material. Fifth cause, that is the drainage through the main abdominal wound often causes bust abdomen. So when drainage is required, it should be employed through a separate step incision. Now the clinical features. It is twice as common in men than in women. It is more often seen in patients over 60 years of age. This is usually occur between the 6th and the 10th day of the postoperative day. Now the management. Bust abdomen is a case of surgical emergency and the nurse in charge of the operation theatre should be immediately informed to make the theatre ready for the operation. The anesthesia is called for immediately. The abdominal wound should be immediately covered with a towel wrung by the warm saline. A nasogastric tube should be inserted to decompress the stomach. Intravenous fluid therapy should be started immediately. Now the operation. Under general anesthesia, the sterile pack is removed. There we can also give the spinal anesthesia. Not necessary to give general anesthesia. The abdominal wound is covered with the sterile packs and the surrounding skin is cleaned and painted with the antiseptic solutions. The abdomen is draped. The sutures are taken away. Any protruding contents of the abdomen are gently washed with normal saline and pushed into the abdomen with warm wet mop. Then metal sutures are used and passed through soft rubber and plastic tubes before tying, so that these sutures cannot cut out through the skin and to minimize tension on the suture line. Parenteral antibiotic therapy is started immediately. Prognosis worsened due to the delay in diagnosis. Now second point of this lecture is the incisional hernia. that is also called as a ventral hernia and postoperative hernia. An incisional hernia is one which occurs through an acquired scar in the abdominal wall caused by the previous surgical operation or an accidental trauma. Scar tissue is inelastic and can be stretched easily. It subjected to the constant strain. Now the etiology: defect with the patient in incisional hernia, obese individuals with lax muscles, patient suffering from chronic cough which may continue in the early postoperative period and will lead to incisional hernia, undue abdominal distension in the early postoperative period, malnutrition, patient with severe anemia, hypoproteinaemia or vitamin C deficiency may predispose to incisional hernia. Dear friends, here is the image on your screen. You are watching the typical incisional hernia seen on. There is the incision and the bulging of the abdominal wall and the skin is clearly seen. That is the incisional hernia. This is the animated picture on your screen. You are seeing there is a incisional hernia. The loop of the intestine come out from the abdomen. Now, second point is the fault during operation to develop the incisional hernia. Injury to the motor nerve supplying the area. Certain incisions are vulnerable to cause nerve injury, that is the coccous subcostal incision for cholecystectomy often inflicts the injury to the 8th, 9th and 10th intercostal nerve. Battle's pararectal incision for appendicectomy. McBurney's incision for appendicectomy may be injured the subcostal or ilioinguinal nerve. Particularly care was not taken during closure of the wound, particularly the deeper layers. Hemostasis was not perfect or the tissue were manhandled, so that early postoperative infection was the result. Tube drainage through the laparotomy wound. Certain incisions are more liable to cause incisional hernia, that is the midline infraumbilical incision for cesarean section. Now the third cause is the postoperative causes. First is the infection. This seems to be the commonest cause. Next is the postoperative cough and distension. Postoperative peritonitis due to more chance of the wound infection. Next cause is the too early removal of the sutures. Steroid therapy in the postoperative period. Steroid therapy causes for the wound dehiscence or the infections because it is immunosuppressive therapy. Pathology: careful closure of the wound is extremely important to prevent incisional hernia. Wound infection often causes disruption of sutures, thus the muscles are separated by weak scar tissue. Now the clinical features. First, the history of previous operation or a trauma is often noticed. Patient may give the history of the wound infection. Now the age. Incisional hernia may occur at any age but more common in fatty elderly females. Now the symptoms. The commonest symptoms are the swelling and the pain. Sometimes attack of subacute intestinal obstruction may occur leading to abdominal colic, vomiting, constipation and distension of the abdomen. Strangulation through the uncommon is liable to occur at the neck of the small sac or in the locule of the large hernia. Now on the examination, the old scar is seen with the swelling. Usually the swelling is reducible and an expansile curve impulse is present. The defect in the abdominal wall is often palpable. These cases must be differentiated with differential diagnosis like a deposit of the tumor, an old abscess, a hematoma and with the foreign body granuloma. Now the types of the incisional hernia are two distinct types of the incisional hernia should be recognized as the principle of the treatment are different in these two cases. In type 1, this hernia is situated in the upper abdomen or in the midline of the lower abdomen. There is a wide gap in the musculature. Risk of the strangulation is almost negligible. This hernia can be treated by simple abdominal corset. In type 2, this hernia is situated in the lateral part of the abdomen. The defect in the musculature is relatively small and irregular. Now the treatment. First, preventive treatment. If the patient is obese, weight should be reduced by dieting if an elective operation has to be performed. If the patient has a tendency of chronic bronchitis, it should be treated first. Deeper layers must be sutured with due respect. All precautions should be adopted to prevent immediate postoperative wound infection. Second line of treatment is the conservative treatment. This method cannot be adopted if the hernia is irreducible. After reducing the hernia, a belt is fitted with the suitable pad so that the hernia does not get an opportunity to come out. Third line of treatment is the operative treatment. This is always indicated in type 2 cases and irreducible type 1st cases. Now the operation, an elliptical incision is made enclosing the area of the unhealthy skin. The unhealthy skin is gradually dissected off the sac, which is nothing but a redundancy of peritoneum. If the sac is loculated and very adherent it is better to open the sac around its neck. The content are freed. Adherent omentum may be ligated and removed along with the sac. Repair of the hernia depends on the type of the hernia and its size. Following are the different methods, one which may be applied. Now the first method is the anatomical restoration. This is suited for small hernia with minimal scar. And second is the approximation of the rectus sheath. This is only performed in case midline hernia, particularly below the umbilicus. Here also each layer is separated individually. The peritoneum is first sutured. The anterior rectus sheaths are now freed from the underlying rectus muscles. The rectus muscles of the both sides are sutured in the midline. Some overlapping may be done. Now the anterior rectus sheath is sutured in the midline if possible by overlapping. To reduce the tension, one may have to make release incision vertically on the lateral part of the rectus sheath. Now the third is the keel operation. In this operation, the hernial sac is not opened but is pushed back into the abdomen. With non-absorbable sutures, it is pleated so that it projects into the abdominal cavity. A few layers of the sutures are applied one after the other till the healthy margins of the muscles and aponeurosis are brought close. Now the margins of the healthy muscles and aponeurosis are sutured to each other. As in this operation, the hernial sac is pushed into the peritoneal cavity in a pattern which on cross section looks like the keel of a ship. That is why this operation is called as the keel operation. Now the fourth is the Cattell's operation. In this operation, the hernial sac is dissected out with equal care has been taken as described in the earlier operations like keel operations and anatomical restoration. But the sac is open. The viscera are reduced after freeing the contents from the sac. The peritoneum is repaired. Now the fifth type of operation is a repair by the facial sutures or skin ribbon. This operation is more or less similar to hernioplasty. This type of repair is necessary when the muscular defect is considerable and cannot be closed without tension. The peritoneum is freed and is sutured. The other layers in the margins are separated, particularly the muscle layers. The defect is closed with the facial sutures in an interfacing manner for muscles of one side to the muscles of the other side. The interlocking suture is made in the form of the lattice work or darn. Sixth type of the operation is the mesh closure. These are becoming increasingly popular. These incision and the sac are dealt with similar as done in the previous operations. The deficiency in the abdominal wall is easily made good without tension by laying and stitching a sheet of the tantalum gauze or a mesh made of dacron or marlex or polypropylene to the surrounding aponeurosis. Polypropylene mesh and expanded polytetrafluoroethylene, that is the PTFE, are mostly used nowadays successfully in the repair of the incisional hernia. Repair with synthetic mesh is only advised when the defect is very large and cannot be closed effectively by the autogenous tissues. It cannot be used routinely as there is an increased chance of the infection. Collection of the oozing fluid inside the wound acts as a good nidus of infection. The following points should be considered whenever a synthetic mesh is used. First is the asepsis should be maintained at all costs. Too much handling of the tissue should be minimized. Hemostasis must be carefully maintained. Even the pre-sterilized mesh should be handled as little as possible. And the next point is the extra mesh may be used in another patients only after autoclaving. Not more than 2 autoclaving should be advised. The mesh should be placed as deeply as possible. Under no circumstances the intestine should be allowed to come in contact with the mesh lest dense adhesion should be formed. The mesh should not be used just under the skin. The mesh should be sutured all round with fine proline sutures. The next care should be taken that a suction drainage in the form of the Redivac should always be used to aspirate the oozing fluid and thus to prevent the infection. Next point is the local antibiotics and post-operative parenteral antibiotics should be used. Next care is to be taken for synthetic mesh is the nasogastric decompression and intravenous fluid aspiration should be continued post-operatively. Nothing by mouth is allowed till bowel sounds are clearly heard. Early ambulation is not encouraged, but movements of the legs and exercise of the legs are encouraged. Patient must not resume work and strenuous exercise for next 6 months. 2 points should be borne in mind. First, the prosthesis should be implanted deep in the muscles of the abdominal wall on top of the posterior rectus sheath on fascia and transverse sheath. And the second point is the prosthesis should extend far beyond the borders of the myoaponeurotic defect. Next point is the muscle pedicle flaps. This is the 7th type of the operations in the incisional hernia. Defect in the lower abdominal wall below the umbilicus may be reconstructed using active and viable muscles belly. Two muscles are particularly suitable for the purpose. These are the tensor fasciae lata and the rectus femoris. Now the post-operative care, gastric decompression and the intravenous fluid are the key points in the post-operative care. Nothing should be given by mouth till the peristalsis returns. Early ambulation is not much encouraged. Though the leg moved are advised, the patient should not do any strenuous exercise for next 6 months. Now the next point is divarication of the recti. This condition means that the two recti muscles separate from each other and a good gap exists between the two recti muscles. Now the causes behind this condition, first is the multiple pregnancies, second is the repeated midline abdominal operations in which the linea alba may stretch. The anatomical pathology is the two recti are inserted to the pubic close to each other, but their origin are quite apart from the anterolateral aspects of the lower rib. When the recti contracts, the upper portion tends to move apart from each other. Moreover, contraction of the oblique and transverse abdominis muscles is added to this. So, it is not surprising that the recti can separate a few inches from each other if the linea alba is weak. Dear students, you can watch a good picture on your screen, that is there is a normal abdomen and diastasis of the recti, that is the diversion of the recti. The distance between the two recti muscles are big. There is a clear cut picture of the rectus abdominis, the linea alba, the transverse abdomen and oblique muscles of the abdomen is clearly seen, and this is the divarication of the recti. Clinically you can see on your screen. Now the clinical features of this condition is principally seen in elderly multipary. During straining, abdominal contents bulge through the gap between the two recti muscles. On examination, one can easily detect the gap between the two recti through which fingers can be introduced. A similar condition of divarication of the recti may be seen in babies, particularly above the umbilicus. Now the treatment of this condition is, as this condition is usually symptomless and there is hardly any danger of the obstruction or strangulation, operation is usually not advised. In case of children, also no treatment is required as spontaneous cure is almost inevitable as the child grows. An abdominal belt should be advised. Now the next point and the final point of this lecture is the lumbar hernia. There are three types of the lumbar hernia. The first two are the primary lumbar hernia, which come out through the superior lumbar triangle and the inferior lumbar triangle. The third one is an acquired lumbar hernia and is better called an incisional lumbar hernia. First, superior lumbar hernia. This is rare than the anterior lumbar hernia. Superior lumbar hernia is the protrusion of the abdomen contents through the superior lumbar triangle, which is bounded above by the 12th rib, medially by the sacrospinalis and laterally by the posterior border of the obliquus internus abdominis. Second is the inferior lumbar hernia is more common than the superior one, and the hernia protrudes through the inferior lumbar triangle or lumbar triangle of Petit's. This triangle is bounded below by the crest of the ilium, medially by the anterior border of the latissimus dorsi and laterally by the posterior border of the obliquus externus abdominis. Now the third type is the incisional lumbar hernia, may occur in the lumbar region following an operation or an infected kidney or drainage of the lumbar abscesses in which the wound gets infected post-operatively, or next point is the following paralysis of the muscles of the lumbar region either due to the injury of the nerve supplying these muscles or due to the poliomyelitis. This is also known as the phantom hernia. Dear students, here is the image on your screen. You can see the back posture of the patient, that there is the left side of the lumbar hernia is clearly seen on the picture, and second is the post-operatively. This is the another picture of the right lumbar hernia clearly seen, and this is the third image. You can see the muscular layers of the back. There is the superior lumbar muscles, transverse muscle and internal oblique muscle. There is a triangle on the both sides. These are the weakest point in our back region, latissimus dorsi muscle, and this triangle the lumbar hernia can develop. Now the swelling is, clinical features are, the swelling is reducible, impulse on cupping is also present. Differential diagnosis, when there is a reducibility and impulse on cupping, diagnosis may not be difficult, yet the following conditions should be kept in mind. That is the lipoma and a cold abscess pointing to the region, and phantom hernia due to the local muscular paralysis as discussed above. Now the treatment is, primary lumbar hernia is treated by the herniotomy or repair of the gap, that is the herniorrhaphy. Incisional hernia or phantom hernia is treated as the incisional hernia, as I discussed earlier. Now, the third one is the obturator hernia. It is an extremely rare condition. It means hernia occurs through the obturator foramen transferred by the obturator vessels and nerve. This obturator foramen is wider in females, and that is why it is about 6 inches more common in women. Clinical features: most of the patients are old women above 60 years of age who have lost considerable fat. Obturator hernia often gets strangulated as it comes out through an opening surrounded by osteoporosis. In about half of the cases of the strangulation, pain is referred along the obturator nerve to the knee joint of the corresponding side by its articulate branch. Only rectal or vaginal examination can detect the tender swelling in the region of the obturator foramen. Now the treatment: operation should always be performed as the strangulation is very common. Abdominal approach is usually preferred by lower parametric incision, and the femoral approach, a vertical incision is made extending downwards from the inguinal ligaments 2 cm medial to the femoral vessels. Dear students, you can watch a good videos on YouTube for the burst abdomen, incisional hernia operations, the divarication of recti, lumbar hernia, and for the obturator hernia to clear your concepts. Now, here is the end of our lecture number 46, that is the burst abdomen and the incisional hernia. Thank you.